my name is Todd Horowitz. I am the Chief of Anesthesiology at Delray Medical Center in Delray Beach, Florida. We're going to discuss CLEVIPREX or clevidipine. We'll give a brief product overview, go over the efficacy data, the safety data, and the dosing and administration. Let's get right to the deck. CLEVIPREX or clevidipine. CLEVIPREX is a dihydropyridine calcium channel blocker indicated for the reduction of blood pressure when oral therapy is not feasible or not desirable. It works by selectively dilating arterial smooth muscle via calcium channel blockade, reducing exclusively SVR. It comes ready to use in a 50 or 100 ml bottle, and it has a low volume and non-weight-based dosing algorithm. Next, we're going to discuss the important safety information for CLEVIPREX. CLEVIPREX is contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products. Patients with defective lipid metabolism seen in conditions such as pathologic hyperlipemia, lipoid nephrosis, or acute pancreatitis if it is accompanied by hyperlipidemia, and severe aortic stenosis. CLEVIPREX is intended for intravenous use only. Use aseptic technique and discard any unused product within 12 hours of stopper puncture. Hypotension and reflex tachycardia are potential consequences of rapid upward titration of CLEVIPREX. If either occurs, decrease the dose of CLEVIPREX. There is limited experience with short duration therapy with beta blockers as a treatment for CLEVIPREX-induced tachycardia. Beta blocker use for this purpose is not recommended. CLEVIPREX contains approximately 0.2 grams of lipid per ml, or 2 kilocals. Lipid intake restrictions may be necessary for patients with significant disorders of lipid metabolism. Dihydropyridine calcium channel blockers can produce negative ionotropic effects and exacerbate heart failure. Monitor heart failure patients carefully. CLEVIPREX is not a beta blocker, does not reduce heart rate, and gives no protection against the effects of abrupt beta blocker withdrawal. Beta blockers should be withdrawn only after a gradual reduction in dose. Patients who receive prolonged CLEVIPREX infusions and are not transitioned to other antihypertensive therapies should be monitored for the possibility of rebound hypertension for at least 8 hours after the infusion is stopped. There is no information to guide use of CLEVIPREX in treating hypertension associated with pheochromocytoma. And most common adverse reactions for CLEVIPREX, which are defined as greater than 2%, are headache, nausea, and vomiting. CLEVIPREX rapidly lowers arterial blood pressure. You have titratable, fast onset of action. In perioperative patients, CLEVIPREX produces a 4 to 5% reduction in systolic blood pressure within 2 to 4 minutes of initiation. An approximately 1 to 2 milligram per hour increase will generally produce an additional 2 to 4 millimeter of mercury decrease in systolic pressure. The initial phase half-life of CLEVIPREX is roughly 1 minute. In most patients, full recovery of blood pressure is achieved in 5 to 15 minutes after the infusion is stopped. CLEVIPREX is rapidly metabolized by esterases in the blood and extravascular tissue to an inactive carboxylic acid metabolite. The dosing of CLEVIPREX is independent of hepatic and renal function, and at clinically relevant concentrations, clevidipine and its metabolites do not inhibit or induce the cytochrome P450 enzyme system. The potential for CLEVIPREX to interact with other drugs is low, and the primary metabolite has no antihypertensive properties. Next, we're going to discuss clinical efficacy. CLEVIPREX has blood pressure reduction proven in a range of clinical settings. We're going to discuss the efficacy data from ESCAPE-1, ESCAPE-2, ECLIPSE. Then we're going to move on to the severe hypertensive trial Velocity and the intracerebral hemorrhage trial Accelerate. Now let's take a deeper dive into the individual trials. First, we're going to discuss ESCAPE-1. The ESCAPE-1 trial was preoperative hypertension. It was a randomized, double-blind, placebo-controlled phase 3 study to determine the safety and efficacy of CLEVIPREX in treating preoperative hypertension. There were 105 patients enrolled, and they were all cardiac surgery patients. The key inclusion criteria included a systolic blood pressure greater than 160 millimeters of mercury, and the patients were clinically assessed as needing a greater than or equal to 15% reduction in systolic blood pressure. Patients started CLEVIPREX at 1 to 2 milligrams per hour, and the dose was doubled every 90 seconds up to a dose of 16 milligrams per hour, or until the desired systolic blood pressure was achieved. At doses above 16 milligrams per hour, dose increments were 7 milligrams per hour. The treatment was continued for at least 30 minutes, up to a maximum of 1 hour, or the induction of anesthesia. The primary endpoint was the incidence of treatment failure, which was defined as the inability to decrease systolic blood pressure by greater than or equal to 15% from baseline, or the discontinuation of study treatment for any reason within the 30-minute period after the drug initiation. The efficacy for CLEVIPREX in ESCAPE-1 was 92.5% compared to 17.3% for placebo. And in ESCAPE-1, the target systolic blood pressure reduction, which once again was defined as a greater than or equal to 15% reduction from baseline, was achieved with a median time of 6 minutes. ESCAPE-2 was a very similar study to ESCAPE-1, except this discussed postoperative hypertension instead of preoperative hypertension. It was also randomized, double-blind, placebo-controlled phase 3 trial to determine the safety and efficacy of CLEVIPREX in treating postoperative hypertension. There were 110 patients enrolled, and once again, these were all cardiac surgery patients. The patients were enrolled if their systolic blood pressure was greater than or equal to 140 millimeters of mercury, and they were clinically assessed as needing a greater than or equal to 15% reduction in systolic blood pressure. Patients were started at 1 to 2 milligrams per hour, and the dose was doubled every 90 seconds up to, once again, a 16 milligram per hour dose, or until the desired systolic blood pressure was achieved. At doses above 16 milligrams per hour, dose increments were 7 milligrams per hour, and the treatment was continued for at least 30 minutes up to a maximum of 1 hour. In ESCAPE-2, the treatment success rate was 91.8% for CLEVIPREX versus 20.4% for placebo. Once again, the primary endpoint was the incidence of treatment failure, defined as the inability to decrease systolic blood pressure by greater than or equal to 15% from baseline, or the discontinuation of study treatment for any reason within the 30-minute period after the study drug initiation. And similarly to ESCAPE-1, the target systolic blood pressure reduction was achieved with a median time of 5.3 minutes. Next, we're going to move to ECLIPSE. ECLIPSE was 3 parallel, prospective, randomized, open-label studies in patients undergoing cardiac surgery at 61 medical centers. There were 1,506 patients enrolled evenly across 3 arms of the trial. The trial was broken into a perioperative phase and a postoperative phase. Perioperatively, CLEVIPREX went head-to-head against nitroglycerin and nitroprusside, and postoperatively, CLEVIPREX went head-to-head against nicardipine. The primary endpoint in ECLIPSE was safety, defined as the incidence of death, heart attack, stroke, or renal dysfunction out to 30 days versus comparators. The study was not powered for non-inferiority or superiority. Secondarily, efficacy was measured by looking at the magnitude and duration of blood pressure excursions above or below a predefined systolic blood pressure range versus comparators. Blood pressure control was assessed by measuring the magnitude and duration, or area under the curve, of systolic blood pressure excursions outside the predefined pre- and postoperative systolic target range of 75 to 145 millimeters of mercury, and the predefined intraoperative systolic blood pressure range of 65 to 135 millimeters of mercury. The table below looks at the median area under the curve for CLEVIPREX versus the comparator treatment arms. In general, blood pressure control was similar with the 4 treatment arms. Looking more closely at the median area under the curve for CLEVIPREX versus the comparators, one can see that there is statistically significant improvement in the area under the curve for CLEVIPREX against nitroglycerin and nitroprusside in the perioperative phase, and CLEVIPREX versus the comparators in the overall, suggesting there is less variability in blood pressure. Next, we're going to move to Velocity, which was an acute severe hypertension trial. It was a prospective, open-label, single-arm phase 3 trial to determine the safety and efficacy of CLEVIPREX for treating acute severe hypertension. There were 126 patients enrolled with a 117 modified intention to treat. The patients were admitted to the ED or ICU when they presented with acute severe hypertension. The key inclusion criteria included a systolic blood pressure greater than 180 millimeters of mercury and/or a diastolic greater than 115 millimeters of mercury. The systolic blood pressure target range was pre-specified, patient-specific, and calculated as a 20 to 40 millimeter of mercury range from upper limit to lower limit. It was selected per the treating physician's discretion and according to the patient's presenting condition, baseline blood pressure, and the presence of comorbidities. The CLEVIPREX infusion was initiated at 2 milligrams per hour or 4 mLs per hour and maintained for the first 3 minutes. CLEVIPREX was titrated up as tolerated by doubling the dose up to a dose of 32 milligrams per hour every 3 minutes until the pre-specified systolic blood pressure target range was achieved within 30 minutes. Blood pressure monitoring was via a BP cuff, and CLEVIPREX was titrated up or down to maintain the desired long-term systolic blood pressure reduction. Treatment with CLEVIPREX was continued for a minimum of 18 hours. The efficacy for CLEVIPREX was 88.9% of patients achieving the target blood pressure within 30 minutes. The target systolic blood pressure range achieved with a median time of 10.9 minutes. The mean duration of infusion was 21 hours. Treatment with CLEVIPREX resulted in a low rate of overshoot in velocity. 1.6% of patients, or 2 patients, experienced overshoot within the first 3 minutes after start of infusion. These 2 patients continued with CLEVIPREX beyond the 18 hours without experiencing any adverse events. In this study, the incidence of adverse events leading to study drug discontinuation was 4.8%. Now we're going to move on to ECCELERATE. This looked at hypertension in intracerebral hemorrhage patients. The study type was a multicenter prospective open-label pilot phase 3b study. The purpose was to evaluate the efficacy and safety of CLEVIPREX in managing hypertension in patients presenting within 12 hours of symptom onset of ICH. There were 35 patients enrolled, and the key inclusion criteria included CT evidence of ICH, presentation within 12 hours of ICH symptom onset, and a systolic blood pressure greater than 160 millimeters of mercury. CLEVIPREX was initiated at 2 milligrams per hour and titrated up every 90 seconds until the systolic blood pressure was less than 160 millimeters of mercury. CLEVIPREX was titrated to maintain systolic blood pressure within the specified target range of 140 to 160 millimeters of mercury for a minimum of 30 minutes to a maximum of 96 hours. Blood pressure was monitored continuously via arterial line. In ECCELERATE, the median time to achieve target systolic blood pressure range was 5.5 minutes. All patients achieved the target systolic blood pressure within the 30-minute window, and 96.9% achieved that target systolic blood pressure with CLEVIPREX as monotherapy. Mild to moderate hypotension was reported in 3 patients and resolved with dose reduction or drug discontinuation. CLEVIPREX is not indicated for the prevention or treatment of ICH. Next, we're going to move on to clinical safety. Common adverse events by day 7 or discharge versus placebo in the perioperative setting were the following. In ESCAPE-1, pyrexia was 18.9% for CLEVIPREX, 13.7% for placebo. Atrial fibrillation was 13.2% for CLEVIPREX and 11.8% in placebo. For acute renal insufficiency and failure, it was 9.4% for CLEVIPREX and 2.0% for placebo. And for nausea, it was 5.7% for CLEVIPREX and 9.8% for placebo. In ESCAPE-2, nausea was 21.3% for CLEVIPREX and 12.2% for placebo. Atrial fibrillation was 21.3% for CLEVIPREX and 12.2% for placebo. And insomnia was 11.5% for CLEVIPREX and 6.1% in placebo. It's important to mention that in ESCAPE-2, the CLEVIPREX arm had an atrial fibrillation rate of 21.3% versus a placebo rate of 12.2%. There were greater than 100% more patients enrolled in that CLEVIPREX arm of ESCAPE-2 that had valvular surgery versus CABG alone. And an examination of the ESCAPE-1 data for atrial fibrillation reveals a very minor difference between CLEVIPREX and placebo. And lastly, in the large safety trial of ECLIPSE, where over 1,500 patients were enrolled, we do not see any trend in the increase of atrial fibrillation. It's worth noting that in ESCAPE-1, there was an increased incidence of acute renal failure in the clevidipine arm versus placebo. That was 9.4% versus 2%. However, this exact point was looked at much more carefully in the ECLIPSE data set, where many more patients received CLEVIPREX for longer periods of time. And in the ECLIPSE data, there was no significant difference in acute renal dysfunction or failure compared to the comparator arms. Next, let's look at the serious adverse events for ECLIPSE. This table shows the serious adverse events reported by day 7 or discharge. As previously stated, the atrial fibrillation for the CLEVIPREX arm of 752 patients was 2.4%, and all comparators was the same at 2.4%. For respiratory failure, 1.1% for CLEVIPREX, 2.5% for the comparators. For acute renal failure, 2.3%, and similarly 1.7% for comparators. For ventricular fibrillation, 0.9% for CLEVIPREX, 1.5% for all comparators. For cardiac arrest, 0.5% for CLEVIPREX, 1.1% for all comparators. And lastly, for cerebrovascular accident or stroke, 0.5% for CLEVIPREX and 1.1% for all comparators. The adverse events observed within 1 hour of the end of the infusion were similar in patients who received CLEVIPREX and those who received comparator agents. And the incidence of adverse events leading to study drug discontinuation was 5.9% for CLEVIPREX and all active comparators 3.2%. No adverse reaction was more than 2% more common with CLEVIPREX compared with the average of all the comparators. Next, we're going to discuss the dosing and administration of CLEVIPREX. CLEVIPREX is a low-volume infusion and has a non-weight-based dosing regimen that is independent of renal or hepatic function. It is administered intravenously by a dedicated central or dedicated peripheral line. It's a single-use emulsion that contains 0.005% EDTA to inhibit the rate of growth of microorganisms for up to 12 hours. So it has a 12-hour stopper puncture. It's metabolized by esterases in the blood and extravascular tissues, and therefore elimination is unlikely to be dependent on hepatic or renal dysfunction. CLEVIPREX is available in 50 ml and 100 ml single-use vials, and it's concentrated at 0.5 milligram per ml. CLEVIPREX comes as a 50 ml vial, which usually will last somewhere between 4 to 6 hours, or a 100 ml vial, which usually will last between 8 and 12 hours. Because CLEVIPREX is a low-volume infusion, it is crucial to prime the IV tubing and check for dead space. The starting dose of CLEVIPREX may be as low as 2 mL an hour. Therefore, if there is any dead space, you will not see the effect of your drug for potentially a long period of time. Ensure CLEVIPREX is getting to the patient by once again checking for dead space. In review, CLEVIPREX is a dihydropyridine calcium channel blocker indicated for the reduction of blood pressure when oral therapy is not feasible or not desirable. CLEVIPREX is contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products. Patients with defective lipid metabolism seen in conditions such as pathologic hyperlipemia, lipoid nephrosis, or acute pancreatitis if it is accompanied by hyperlipidemia, and severe aortic stenosis. CLEVIPREX is intended for intravenous use only. Use aseptic technique and discard any unused product within 12 hours of stopper puncture. Hypotension and reflex tachycardia are potential consequences of rapid upward titration of CLEVIPREX. If either occurs, decrease the dose of CLEVIPREX. There is limited experience with short-duration therapy with beta blockers as a treatment for CLEVIPREX-induced tachycardia. Beta blocker use for this purpose is not recommended. CLEVIPREX contains approximately 0.2 grams of lipid per ml, or 2 kilocals. Lipid intake restrictions may be necessary for patients with significant disorders of lipid metabolism. Dihydropyridine calcium channel blockers can produce negative ionotropic effects and exacerbate heart failure. Monitor heart failure patients carefully. CLEVIPREX is not a beta blocker, does not reduce heart rate, and gives no protection against the effects of abrupt beta blocker withdrawal. Beta blockers should be withdrawn only after a gradual reduction in dose. Patients who receive prolonged CLEVIPREX infusions and are not transitioned to other antihypertensive therapies should be monitored for the possibility of rebound hypertension for at least 8 hours after the infusion is stopped. There is no information to guide use of CLEVIPREX in treating hypertension associated with pheochromocytoma. And most common adverse reactions for CLEVIPREX, which are defined as greater than 2%, are headache, nausea, and vomiting. Thank you for your attention, and this now concludes our slide presentation.